it's not a good indicator. But on your sodium fluoride, you're talking about active uptake. So
that's right.
So
some areas were completely inert with just, let's say, CT positive calcium, but nothing on PET. And also vice versa. Sometimes we would see sodium fluoride uptake, but we see nothing at all on CT. And what we think is happening there is that we've got areas of very, very small microcalcification, too small, below the spatial resolution limit of CT. And we're picking them up in the very earliest stages where there's active exposure of hydroxyapatite and binding and mineralization going on, and we're highlighting that with the sodium fluoride. Another study we've got going, we're following those patients up for 2 and 3 years to see what happens to those areas, whether in fact they do become calcified on CT over time.
Right, so your hypothesis that there's actually a window of time where those plaques are vulnerable, where they're liable to rupture, and then they become stable. So if you've got a large area of sodium fluoride uptake, these people are liable to have an acute heart attack. Is that what you're saying?
That's the completely unproven hypothesis, but yeah, that's what we think is happening.
Right.
Clearly, we need a much larger natural history study to prove that, but certainly in this snapshot of 40 stable patients, 40 unstable patients, that was the kind of story that we were getting. It was a good marker of a very recent event that had happened already,
right?
Which we saw in the post-MI group, who were having angiography, within the throes of the infarct within the first few hours. But in the stable group of patients with just common or garden angina, no recent heart attack, we did find these areas that were also lighting up. And then when we put the IVUS camera down, we saw that those lit up areas were vulnerable. So we think it also shows that, as you say, in that window, maybe that those plaques were becoming dangerous for the patients, even though they hadn't yet had an event.
So really what you want is a longitudinal study where you're going to actually show events in these patients, and then you'll be able to know whether it's predictive.
Exactly.
That's very exciting, because that means that we know which group of patients to intervene aggressively, or presumably.
That's right. Yeah.
And
work
out
unproven.
Right.
But the idea is exactly that.
But what intervention are you going to do? What's the right kind of intervention? Is it because there's some doubt around whether really stenting and things help. I mean, is it ultra aggressive medical therapy? Is it stenting? What's the right thing to do in people that are in this hyper dangerous situation, I guess?
Yeah, I mean, the answer is nobody knows yet, but the line that we have taken when we've been writing grants around this, just doing exactly what you just suggested, following patients with very high levels of uptake, is not stenting. We think that would be too much of a step change without any evidence, really. So what we're suggesting doing is, intensive medical therapy, going from a low or medium dose statin up to a high dose statin, and every other secondary risk factor modification that you could think of, aggressive control of diabetes, blood pressure, and seeing, following the patients for events.
Yeah, and it's tricky. I mean, would you be advising aggressive exercise in these patients or not? I mean, it's exercise is good in general,
it is
but is it good in these people?
Well, we don't know for certain, but that's probably one further study down the line, to see exactly which lifestyle changes do work. But there was some earlier work ages ago now that showed that even aggressive lifestyle modification with no medications could lower the FDG uptake in your carotid and aorta by about 10 or 20%.
Right.
Over a 1 year period. That was a study from South Korea. So even, looking after yourself really well for 12 months was enough to reduce inflammation, if you like, in the arteries without any going near a statin.
Right. Or a gastric bypass, or those other sort of interventions as well, I guess. Possibilities.
Yeah.
I mean, and again with lifestyle, they're very much a cultural thing. Having worked in the UK and then coming here, and having previously been here, the difference in lifestyle, I'm afraid, between the UK and Australia is dramatic. As I hate to say it, as our recent cricket team might evidence that. Those kind of interventions really vary a lot from place to place. And I did some work in Glasgow, for example, and there's some big difference in lifestyles between places, and that kind of thing might have a factor.
No, I think you're right. I mean, Glasgow's got one of the highest rates of coronary artery disease in the whole world, so most of that is probably genetic, but there's, yeah, as you say, I'm sure if you compare to, 50 to 70-year-olds in Melbourne and 50 to 70-year-olds in Glasgow, there'd be a decent difference there. Yeah.
Yeah. Well, I know we've got a patrol in my surf club that have to compete to qualify for every year to get in. So they have to pass a fitness test in the surf, and all of them are over 60.
Really?
Some of them are over 70 even. So
Wow.
it's something you're not likely to see in the UK. So
Not surfing, but in general, around here, there's all sorts of options. But yeah, I've lived in Australia too, so I know there's certainly there's a lot more emphasis on finishing work at 5 and going out and doing some exercise and a lifestyle thing. Yeah.
So the mechanism you're thinking about for this, get back to what we're talking about, is simply calcium deposits. I mean, we used to have phytate imaging, technetium phytate imaging for measuring acute infarcts, which was believed to be calcium. Is it? So it is simply that you think that you're looking at, or is it something else?
No, we think it's that. So we think there's a vulnerable or recently ruptured plaque where there's been some inflammation followed by necrosis, and then the area would become calcified almost as a means of the body starting the healing process. So hydroxyapatite is exposed during that process, and that's where we get binding of the sodium fluoride. So it's areas of calcium that are actively turning over, in other words, where there's ongoing calcification activity, as opposed to the more larger areas you might get on a standard cardiac